obviously lends itself and kind of leads itself quite nicely into our next one, which is Dr. Marwan Jumean, who is going to talk to us about when you actually reach for percutaneous mechanical circulatory support.
Good morning. I want to say thank you for inviting me, but anyway, so I'm asked to talk about escalation of pMCS as a continuation of the discussion that we're having today. I was very excited that I'm giving this talk because I thought it was very easy. But I'm evidence-based, I'm talking in front of a lot of people, so we need to make sure that we give you the latest evidence. And then when I start looking for that evidence, I was like, whoa, really? It's just, nothing is out there. And I kept digging and digging and digging, and eventually I was like, it's very frustrating that we don't have really good evidence behind the use of pMCS. So, but you know, I'm a person that, you know, believes in some of the evidence. We know that the escalation of the severity of shock from A to E increases mortality. This has been proven in hospital mortality as well as later on as soon as they get discharged into 1 year. The higher the stage of shock, the worse the outcomes. We know that. I don't like a lot of medications. Why is that? Number one, it's a lot. You know, for me, as a physician coming to the bedside, looking at this, it's very complicated. Number two, there's really no really strong evidence behind the use of MCS, behind the use of medications in shock. And number three, the theory behind resting the myocardium, allowing the myocytes to breathe, which is something that medications don't do, is a very interesting topic and interesting theory behind the use of MCS. And instead of medications, why not just do this? The patient can play on the guitar with MCS, stabilize shock until the next step. I love guidelines, okay? So I looked at the scientific statement from AHA about escalation and de-escalation of MCS. And I think Jason Katz is on that paper. So I apologize in advance. So this is a very busy algorithm. And is it Finding Waldo? What was that book?
Yeah, Where's Waldo?
Okay, Where's Waldo? So let's play a game. Let's look for words on those scientific statements that say reasonable, consider, suggest, and consult. And you'll realize that it's in the entire algorithm that you basically say that.
This is well played.
So this is another graph from this scientific statement that basically say the same thing. Okay, so what about opinions? I respect opinions. This is Sandeep Nathan. Unfortunately, he couldn't make it this year. And he has this beautiful table from A to E. The same thing is all his opinion. The entire thing is just his opinion. So bottom line is, you can do whatever you want. Okay, so I'm going to tell you what I do when we talk about escalation of therapy. We go down to the basics. Okay, basics of shock. SHOCK, I'm not going to bore you with this, but we're going to focus on two things, the hemodynamics and the kinetics. And Dr. Wald pointed out a little bit about the hemodynamics, about perfusion, and it's not just about the blood pressure when you assess patients at the bedside. Okay, when we talk about hemodynamics, and what are we talking about if it's not the blood pressure? Well, we're talking about two different things. Number one, phenotypes, and number two, the hemodynamic goals, your targets during therapy. When you talk about hemodynamic phenotypes, number one, we have to understand that not all cardiogenic shock is created equal. The time of shock presentation and time to identification varies from place to place, from physician to physician, from nurse to nurse. Concomitant shock is frequently present, and cardiogenic shock in it by itself and the therapy with MCS can elicit a profound surge response depending on the time. And we know that the more profound surge response, the delay in the shock presentation or shock stabilization will lead to activation of that surge response that will be detrimental in the form of escalation of the severity stage of shock from A to E. Concomitant shock is frequently present in about 20+% of patients presenting in cardiogenic shock. And then the source response is bad. Once it's activated, no matter what you do, essentially, you're not going to do well. And this is comparing survivors and non-survivors over a span of a few days. So let's use the machine learning and intelligence in identifying phenotypes. And this is a paper from a couple of years ago looking at, okay, well, there are 3 distinct phenotypes of shock. There is the non-congested. Those can be somewhat deceiving. They have low filling pressures, but they have low cardiac output. Their blood pressure is a little bit on the higher side. There is the cardiorenal, where there's evidence of kidney dysfunction. And there's the cardiometabolic, which obviously there's evidence of end organ dysfunction. And we know that the cardiometabolic, or cluster 3, is associated with a higher mortality than cluster 1. And then the hemodynamic goals, when we are managing those patients, what are we targeting? Are we targeting a blood pressure? Are we targeting something else? This is just, again, similar to Dr. Wald's mentioned earlier, is, in a different format. This is looking at cardiac power output. I don't want to bore you with this, but the bottom line is look at the y-axis. Y-axis has a cardiac index. Look at the cardiac index less than 2.2, but look at the mean arterial pressure on the x-axis, 65 and above. So a lot of patients with low cardiac index have high blood pressure, and similarly, a lot of patients with low blood pressure, that MAP goal of 65, they actually have okay cardiac index. So if it's not blood pressure, what do? Lay your hands on the patient, as you heard from the previous lecture. Look at the patient. Also, you have to look at the constellation of multiple different things. Number 1, clinical signs. Urine output. Surgeons figured this out a long time ago. If the patient's peeing, then the hemodynamic status of that body is actually good. Looking at the biochemical evidence, lactate clearance is more attractive than lactate in and by itself. Hemodynamic goals with a Swan-Ganz catheter, and then the health of microcirculation, which was alluded on briefly in the previous lecture. And then maybe including the CLIP score, which looks at all this together, which is kidney function, lactate, interleukin, which is the source response, and the pro-BNP. Lactate clearance, because I think it's important those who have cleared the lactate very quickly have a higher survival rate. And then the kinetics. Okay, when we talk about escalation of pMCS, what are the kinetics? And there are 2 questions that you have to ask. Number 1 is you always have to match the degree of hemodynamic compromise with the hemodynamic support device that you're using, and you have to do it in a timely fashion. And assessing time in shock is very difficult, but this is a very small study, I think from Germany, that looked at time in initiation of pMCS in shock patients, and they found that if they initiate them earlier, they have better survival. So we talked about the hemodynamics, we talked about kinetics, but there are 2 more things that we have to talk about. Number 1 is, what is my exit strategy? Okay, am I working towards the heart to recover? Then I have to think about a device that's going to give the heart the chance to recover. Am I doing this as a bridge to therapy? Then I'm saying, I don't care about the heart, I care about the other organs. So I need to maximize support for the other organs, liver, kidney, et cetera, et cetera. So it's not just a hemodynamic goal with a blood pressure. And number 2 is, what are the local resources? We have to respect that. We heard that from different centers, have different people on the table making the decision. What's your cath lab capabilities, OR capabilities, heart team, who's in that heart team? So it's really not one size fits all. And that's it. Thank you very much. Yes, sir.
I feel like this is you.
I have, first of all, I appreciate you pointing out the utility or lack of utility of our scientific statement, which was basically the take-home point, to be honest with you. So in response to that, I have two questions for you, each with 15 parts. Okay. No, I do have two questions. I remember you invited me here the very first Houston Shock Symposium, and you asked me to talk about what the guidelines say about cardiogenic shock. And with one slide and a mic drop moment, I said, there are no guidelines. So many years later, 6 years later, or whatever, 7 years later, there's still no guidelines for cardiogenic shock. So the first question I have is, what is it going to take to be able to develop consistent consensus guidelines for shock? And then the second question, which I suspect everyone's going to want to hear, you brought it up in the last slide, is how much do you think about what is the downstream resource? What is the exit strategy when you choose your first and potentially second or third temporary MCS device?
I hold grudges, so I heard you make fun of me in 2018, and I just find the right moment to come back and point that out based on papers that you've published. That's number one. But the reality is, if you look at any clinical study in cardiology outside of shock, you see 10,000 patients for a drug approval. It's very difficult to get data outside of expert opinion at this point. And there's a lot of push towards that with severity classification, SCAI, and all that. But there's something lacking. And for example, when it comes with a STEMI, there's a clear definition in EKG. Exactly, everyone knows exactly what to do. This has been studied 20 plus years ago about time to balloon and all that. But we don't have that. We don't know what the ideal time for time to support. What to do. Outside of revascularization and shock, we really have not shown anything that has a mortality benefit. But I'm going to allude to this later on today, and you're going to hear it throughout the weekend. Maybe this is not the right question to ask. That I'm not looking for a mortality benefit. I'm looking to, stability until the next step. And then if the next step is recovery, then I'm going to have to use a device that's going to allow me to do full recovery. We have to have it full and complete. And there is some subjectivity to that. And until we get rid of that subjectivity in the diagnosis and the definition, then it becomes very challenging to have a trial that is reproducible everywhere. And that's why everyone's doing it their way, and they think that they're right, and they're experts in doing this because of X, Y, and Z. But it's a bit more challenging than that. And I'm sure you've seen this, looking at sifting through all the evidence and papers out there, not a lot. Even if you look at the revascularization, the initial shock trial, how many patients were in that? 300 plus patients, that's it. That's it, compared to Horizons AMI that had more than 10,000 patients. So that's one of the challenges.
Well, you answered that question perfectly. Let's hear the...
Okay, so the summary of my talk, if you're on the equivalent of dopamine 5 and up, just go for a device. That's, and see what happens. And again, what type of device you use, I still believe that there is value in balloon pumps, so I use balloon pumps, Impella CPs, so they're, quick to do and deploy in the cath lab. We have 24/7 cath lab. And then the next step is, if someone is crash and burn, ECMO is readily available. You can deploy at the bedside. You guys have seen this a lot of times. And then 5.5 is a very attractive option to allow the LV to recover and giving it the maximum chance to recover based on the information that we have right now. So, but that's how I think about it.
Perfect. Expertly.
We have time for about one question. Sorry.
Sorry. Actually, I needed to ask you this question anyway, so it's a perfect time soon for a project near you. So it was great that you presented this today. Your heart failure nurses have come up with a project. They want to talk to you about
it's really a question outside the symposium. Okay,
I like it.
They want to know about the use of VIS-score in calculating when to initiate MCS. So it's perfect time because it's a project coming to you, just so you know.
Yeah, this is a great, so VIS-score is basically looking at standardized, kind of a number. So if someone uses a lot of epi versus norepi versus dopamine versus vasopressin, just come up with a number so that we can all speak the same language in terms of the amount of pressures the patient is on, and then see if we can use that to triage patients in shock. And we demonstrated that there is a higher mortality based on your VIS-score if you're on ECMO after a certain time period that we published a year ago. But no one knows exactly what that magic number is that will trigger the use of MCS. And I think this is a great topic to discuss for next research, and maybe he can include it in his guidelines in a couple of years.
Consider.
Awesome. Yes, please.
I'm very good at hedging. Very good. Expertly crafted over years.
Awesome.
Right. Destiny, you have a real quick question?
Yes, just a quick question. Hi, Dr. Jumean. I'm glad that you were invited today. When we're talking about escalation to MCS, do you think the issue and also the problem with the data is that we're using MCS as an escalation? Like if a patient comes in, they're in a low cardiac output state in some situation of decompensation, should we quickly go ahead and support the patient and then see if that adjusts our outcomes on the back end? Like you said, there's not much utility, I don't want to say utility, but there's not much evidence that shows that medications are doing the trick. So if we were more proactive about using MCS, do you think on the backside, or do you think that's what's coming, like going ahead and starting? We've already learned that Impella-assisted PCIs are working, right? We're not waiting till a patient V-fibs on a table to do that. So do you think the next wave is going ahead and starting even pMCS, or I'm sure ECMO too, on patients early to go ahead and full support and then work more on a weaning versus escalating?
There's what is ideal and there's the real world. And, implementing that is very difficult. And, they've looked at this in different scenarios. So when you present at 2 a.m. versus at 2 p.m., depending on the time of the year, depending on where the residents are in their training, there's a lot of issues that just from that perspective. So, it's easy to say, at 2 a.m. if you come in shock, the first thing that we do before anything is just deploy this device, and you'll deploy it in 15, 20 minutes the way that you spike, any medication and start on the patient. But the reality is that doesn't happen. So until we have the device that you can quickly deploy, that's going to give you adequate support, equivalent to reaching out to any medication until you temporize this, I don't think that exists. What do you think?
Great. Yeah, I agree.
Yeah. Thank you.
Well, thanks so much.